webinar series. We appreciate the positive feedback and suggestions for future sessions that you've offered us. The 6 weeks that we've been doing this has been an incredible experience, as well as inspiring to be able to be in community with you. Before we start, we have a few ground rules. Your audio and phones will remain muted for the duration of the call. Questions for our speakers can be placed in the Q&A box that you'll see at the bottom of your screen for those of you that are joining by Zoom. Unfortunately, we won't be able to monitor the chat box for questions. We also are on Facebook Live. This is our first time bringing this webinar series to Facebook Live, and we have some of our team monitoring our Facebook Live as well. You can utilize the chat to message all the other attendees during the session. And this webinar is being recorded, and this and prior webinars are available on the CCPH and CHER websites for review and to share with your networks. We are also aware that hackers have successfully accessed Zoom webinars to distribute disturbing images. At any point that we are aware that such attempts are being made to this webinar, we will immediately suspend the session, and we apologize for advance for doing that. We believe that that kind of action is necessary to minimize the further dissemination and possible exploitation that might be shared. So a little bit about today's session. It's a little different than what we've done in the past. While the current pandemic has really laid bare the health inequities and injustices that already existed within our country, it also calls for calls to us to start to think about ways to build community resilience, and also to think about healing. So joining us today are some of the thought leaders in this field as we shed light on the myriad of ways that we can think about resilience and healing in the face of one of the most significant health crises of our day. Today marks the 6th session in our webinar series that has shared powerful and thoughtful information. And joining me today as a co-moderator of the session is Al Richmond, Executive Director of Community Campus Partnerships for Health. Can I ask to have the slides advanced? So our learning objectives for all of our sessions are to share diverse perspectives on COVID-19 and its impact on health equity, to develop a network to support systemic changes in response to COVID-19, and to explore collaborations and partnerships in promoting equity and the response to COVID-19. I want to make sure that folks know that they can use our hashtag #EquityInCovid, and all of our handles are on the bottom of each slide. So please feel free to use that and go ahead and share and continue to create this community. Our first speaker is Dr. Alonzo Plow, the Chief Science Officer and Vice President of Research, Evaluation, and Learning at the Robert Wood Johnson Foundation. Alonzo has been a national leader in public health practice for over 25 years. He came to the foundation from the Los Angeles County Department of Public Health, where he served as Director of Emergency Preparedness and Response from 2009 to 13. In that role, he was responsible for the leadership and management of activities protecting the 10 million residents of Los Angeles County from natural disasters and threats related to disease outbreaks and other public health emergencies. He coordinated activities in emergency operations, infectious disease control, risk communication planning, and community engagement. Alonzo, thank you so much for joining us today.
Thank you, Giselle. I'm very happy to be here, and good morning or good afternoon, depending upon your time zone. I'm going to lead up to the questions that we're going to be talking about resilience and recovery, but I feel obligated to go a little bit through some of the conditions, some of the epidemiology, some of the health equity context that is so important to understand if we are going to get through this and achieve the kind of resilience and recovery and health equity we want in the long run. Clearly, as we see COVID playing out in this nation and internationally, and I imagine in the previous parts of this webinar, you can see, we can see that this tragedy is one of greatly disproportionate risk on populations who really in common have various kinds of marginality that influence their life conditions, so that this virus causes differential mortality, morbidity, and just an unfair experience related to this, to COVID exposure. And when you look at the kinds of things that put people at more risk for COVID, you begin to see the same kind of social determinants that are so important for building resilience and community healing, because we only build those systems by understanding what existing systems, what existing tendencies and institutions have to change. And then it bears mentioning again around COVID, exposes these continued problems and inequities in life conditions. And we see it around jobs that don't have sick leave, isolated elders who are in nursing homes which are underregulated and overly for profit. We see that the millions of uninsured people don't have access to healthcare, which exacerbates the prevalence of and disproportionality of chronic conditions. All of those factors that we know are lifted up and accentuated by COVID. And unless we think about those social conditions, the historical nature and persistence of the problems captured in those policies and institutional decisions, we will not have the ability to build the systems of support and healing and actually togetherness, social fabric that we need. So what I want to start off with then is just a little bit around the road to recovery. It is through understanding of these systemic conditions that need to be changed in social conditions that allow us to recognize what it means to create more stability in those communities than we had prior to COVID. I'll come back to this point again. Resilience is anything but bouncing back. Resilience is understanding the conditions that have that create disproportionate or unfair outcomes related to a disaster and changing them so they are not replicated again over time. That's the path forward. Without that, you replicate the same problem over and over again in the next disaster or the next wave of COVID, which we know is going to happen. So the road to recovery and the road to healing is awareness of those conditions, and particularly significant engagement with communities, community power building, community voice, and shaping what that resilient future needs to look like. It is not a top-down kind of determined resilience. It is a bottom-up kind of resilience. I have been in public health a long time, Los Angeles, Seattle, King County, Boston. And I think part of the path to resilience is that we've seen a disaster management, and particularly at this point, when the virus is still 3 months, it seems like a long time, but it's relatively short time. We have had a kind of national moment of we're all in this together. You see this in many different disasters. The key to resilience is keeping that longer than we usually have, keeping that notion of interconnectivity and we're all in this together, and not forgetting that that is the key to a recovery. So I think that much of what we need to do to heal is continue to have this same notion, shared public notion, that our survival, our resilience, our healing is intertwined, and we need to work on that together. COVID is going to make it really clear that there's going to be a long-term need for healing and well-being, mental health. The economic consequences are going to continue to be long. Resilience and healing is recognizing those conditions and beginning to change those. Healing and resilience in the long run, and I'm reflecting on working on SARS, working on H1N1, um, bringing communities together and making sure that what we do, I'll speak as a former public health practitioner, that we do that in community partnership in a transparent way. Contact tracing, the next wave of vaccine distribution is going to require deep levels of trust and interaction with communities if the recovery period and the healing is to happen. A very important focus will be needed on deep levels of community engagement. I've seen that in every place I've worked around disaster recovery. Resilience, again, resilience is about bouncing forward, about changing those conditions that created the inequity in response. Resilience is not about grit. Marginalized people actually have a tremendous amount of resilience because they deal with situations on a day-to-day basis. We need to lift up, support that voice as we think about the changes that we need to make so that we can come together as a society in an equitable way. I'll end with just a couple of comments. This health equity, social determinants focus is so important. The important role of community voice, power building, rooting recovery and healing in trusted local institutions, addressing and keeping even better knit our social fabric, thinking about well-being, not just absence of disease. All of these things will be very critical to recovery and healing. I'll close with just a few comments on how Robert Wood Johnson Foundation has been approaching this. You might have seen that the first wave of funding we did about a month ago was $50 million for basic humanitarian relief to address those kinds of issues by individuals whose economic conditions have been devastated by the pandemic. We will continue to align all of our existing work, which is aligned around improving health equity toward COVID. And you can look to see many other opportunities throughout this year for opportunities to be funded, particularly because our health equity focus is very well matched to dealing with these underlying conditions that need to be improved if we're going to have a resilient and healing post-COVID period. So let me end with that, and thank you for an opportunity to share a few words.
Thank you, Alonzo. The foundation, the Robert Wood Johnson Foundation, has really in the recent years uplifted ideas around the culture of health. And so could you speak to how at this moment the culture of health becomes even more important, or how you see it kind of shifting or reshifting at this point in time?
Yes, this culture of health, a notion which we define simply as conditions across the country that allow for equitable life and fair life outcomes. Another way to put it is in a culture of health, you would not have these disproportionate COVID impacts on marginalized communities. So, and we have been working toward that long-term goal of building a culture of health, which clearly a future that has more equality than we're seeing now in the COVID outcome. But what is so important about the culture of health framing is it is about what all institutions have to do: public, private, business, government, community organizations, in cross-sectoral, collaborative, and community-driven. People who disproportionately bear these problems have stories to tell, evidence to present, and solutions to offer. So much of what we're trying to do in our work with others around building a culture of health is knitting together that social and institutional fabric to respond better in the future. And I think we are responding now as a nation to COVID-19.
Others have asked about policy recommendations. Do you see any specific policy recommendations emerging out of the current COVID-19 pandemic?
I'll go back to what I said earlier. COVID has unearthed, for those who haven't been looking at it, policy changes that we need to develop more health equity. Policies, I'll just mention just a few. The inequity in the workplace of individuals who have paid leave and sick leave. We need policies that address that. We need policies that I'll put it negatively, it shouldn't be just in a COVID, in a pandemic, that we realize that social sector workers, home care workers, people work in the fields in the Central Valley of California are essential. We need to recognize all the time that they are essential, and they need the kind of benefit, work conditions, and protection packages, insurance, that allows them to be well during non-epidemic times and to have a good chance of equal survival during that. So many policies relate that need to address existing inequalities, housing affordability. All of those are ones that need to be addressed that COVID has lifted up.
Thank you, Alonzo. I'll turn now to Giselle to introduce our next speaker.
I want to remind folks to make sure that they know that they can ask questions in the Q&A box. We did get over 100 questions on registration, so we're trying to integrate and work through some of those as well. Thank you so much for your interest. I'm excited to join my colleague, introduce my colleague Alice Chenal. She is the Director of Quality Improvement for the Rural Health Group here in North Carolina, and she also is on the board for North Carolina Rural and part of their advocacy agenda. Alice, thank you so much for being with us today and to talk more about what it looks like on the ground in your organization and in the communities that you're serving.
Absolutely. Thanks for including rural, and thanks for raising the voice of Federally Qualified Health Center that is a safety net to provide care for our citizens. I would like to take a moment to just define who we are. At Rural Health Group for the past 40 years, we have been the safety net in several of our rural counties. Currently, we serve patients across 6 counties. 2019, 38,000 patients plus were served. Unfortunately, we are a health professions shortage area, therefore, access still continues to be a challenge. Not only access, but also provider shortage continues to be a challenge. Across those 6 counties, we are not only a health center, we are a small business. Over 350 employees, and many of our employees are from the community that we actually have a site. We have 17 sites. We are an integrated health system with behavior health, with case management, and we consider ourselves providing wraparound services. To the point at hand, I would say that posture was really important and is important as we define new normals in a health center environment. Posture meaning health centers across the country, federally qualified health centers as well as lookalikes. We're looking at things from 3 buckets as it relates to shifting from volume to value. We're looking at people, we're looking at infrastructure, and we're looking at care delivery. More specifically, here in Roanoke Rapids and North Carolina, Eastern North Carolina that is, and the other counties that are Rural Health Group sites, we have championed, in my opinion, diversifying visit types. Televisits are, of course, being promoted, and as well as phone visits, and reimbursement is an interesting conversation around that. But as most people that are listening who live and worship and play in rural communities, broadband is a huge issue. So literally we have transformed into curbside. We, of course, are doing some level of televisiting, actually a high volume, as well as phone visits. We have literally taken our iPads out of our kiosks where patients would come in and actually register using those kiosks, and taking them out to a car that a patient may be able to converse and have a visit with their provider. Other things that we're doing that I think are not only transformative, but just moving us along the direction we should be going anyway, but due to COVID, it sped us up. We're optimizing our electronic health record platform, training and staff up, as well as our patient community to understand how to use the portal to get a message through. Downloading that app that's available through our electronic health record to have a video visit where there is a comfort level of doing that. Another area that we are working really hard to move to who needs the most help is risk stratification. Realizing many of our specialty offices were unable to see or take referrals, we were, looking from a risk stratification perspective of, the number of conditions or the number of meds that people were in need of on the panels, and having our case managers reaching out to them to make sure they still had some level of coordination of care around accessing those things. Another opportunity in this unfortunate situation that to some degree was fortunate was chronic care management, having the case managers reaching out and say, hey, we want to wrap a few more services around you to make sure things are okay for you. And then them being able to hear from that voice of a person that they already know and have a relationship with, which, just to pivot a bit, underscores the need for community health workers and more people on the ground to bridge gaps around navigating systems in this type of unusual change. So another area that Rural Health Group is what I would consider on the edge is that we are now a rapid testing site. 3 of our 17 medical sites are providing rapid testing. And it's due to the fact that the mile radius distance of a person being able to actually get to a clinic presents even more challenges. So therefore, rapid testing is made available based on not only the patients that come here, but it's a community resource, and we're really appreciative for that. I'm still fine-tuning what we would consider our workflow for that, because as many of you that are clinicians on the call, workflow changes from day to day in some cases. Another important decision that was made just yesterday when we were having our senior leadership meeting is to ensure that all of our patients who are testing positive are receiving referrals to behavioral health. Not about just being positive with COVID, but making sure that they are being able to talk through life that is not only physical, but emotional, and all of the other tragedies that are being faced around losing loved ones or having loved ones hospitalized and unable to see them. We are also collaborating and aligning. Those terms are used loosely, but when you start thinking about mutually beneficial partnerships, that also, to me, sometimes can be used loosely. So we're having not only our community partners that are health and human service providers, but we're having partners that are payers saying, hey, we've got these members and that are receiving primary care from you all. What can we do to help? Just recently asking about masks. One of the things before I shift to just the resiliency piece, I'd like to mention is that we spent some time talking about what is marginalized for us. And all transparency to a bunch of people who do not know me, I kind of had to sit with that because that's a loosely used term in certain environments that doesn't always fit. It is not a kitchen sink. It is clearly an opportunity to kind of move people out of it's an opportunity to move people from a list and kind of understanding who is the population that's needing this resource or this access. And so we spent some time doing that, and I was really proud of having that opportunity, but I think more time needs to be spent. How do we become resilient? I think there's been a lot of reactions around COVID and not necessarily responding. I don't think we're at a place at this point to understand really what damage or what opportunity we have at this point. I think for those that are in academic training programs, specifically college students, I saw a question about that. This is a time to assess all people that are interested in helping and serving. The assessment is around what do we continue? What do we start? What do we stop? And I think for students that are making the decision to actually move forward with becoming clinicians or some type of public health practitioner or health and human services provider, this is an opportunity to focus on becoming. This is a wide open opportunity to understand what health disparities really mean and how we don't fix it, we'll continue to see it and experience it in disaster after disaster. I think we are resilient. I don't think we are becoming resilient. Much of this, to Alonzo's point, feels a lot like the Hurricane Floyd, in which we experienced in 99, 2016, Hurricane Matthew, and people would say, how are you? And I would say recovery phase number 1. And this is exactly what it feels like in this environment, not just health sectors, but the business sector and just the educational sector. And so everyone is impacted, and health is one of many ways that people are suffering when they don't have adequate needs. So I'm going to stop there and yield this to Al.
Yeah. Alice, thank you so much. You talk a lot about the work at Rural Health, and I wanted to just ask you about what are some of the differences that you have kind of noticed between in rural communities and urban settings where people are facing these particular moments?
Al, communications is a huge issue. People are interested in having a reliable source of information. Unfortunately, that doesn't exist the same way in a rural versus an urban community. Another is not only communications, I would also say access to testing altogether. When I mentioned rapid testing, if you're in an urban area, like past headed 64 to 40 in North Carolina, there are a lot of centers, health sciences centers that are able, on hospitals that are able to offer this rapid testing. We have one major health center in our area that's able to do that. So there's that issue as well. I think just access and sharing and leveraging resources, whether it's PPE, whether it's access to testing, whether it is understanding how the systems are needing to be altered in order to make it work for our community is so very important.
Alice, can you highlight one example of how you have just been amazed at how people have kind of come together in your rural community and how they've kind of like reinforced and encouraged each other to be very resilient in this moment?
Absolutely. As I mentioned earlier, our community understands how to come together. The floods have unfortunately fostered that in ways that it's not just this is who works at the health department and this is who works at the hospital. We've been able through some other venues to come together and have what I would consider multi-sectors to talk and understand each other's work and how we intersect. And so we're doing that. So it was far from let's see what they're doing from let's come together to see how we can help, or just, to share what our challenges are and where the opportunities are. So we're doing that every day. There is a huddle with the health director, hospitals, and different community-based organizations that are working on the ground to get this done. That huddle happens around lunchtime.
Thank you, Alice. We'd like to have you to continue to be on the call, and we're going to introduce our next speaker.
Thank you.
Thank you. So our next speaker is Kira Banks. Dr. Kira Banks is Associate Professor in Clinical Programs at the Department of Psychology at St. Louis University. She is also the Chief Executive Officer of Raising Equity. Welcome, Kira.
Thank you for having me. I really do appreciate the invite, and it's been great to hear what's happening in different corners in terms of funding and rural spaces. And today I want to share a little bit about what's happening in St. Louis and my work in terms of COVID-19 and what was happening before and what will continue to happen beyond. Is it okay if I share my screen? It says I cannot share my screen while others are sharing. Is it possible? I have slides. If not, I can just talk through them.
We're gonna give us just a second.
Oh, yep, there we go.
There you go.
All right. Okay, so I want to talk a little bit about what we've been doing, like I said, here in St. Louis, and how we're doing it. And we really are working from a healing justice framework. And if you are not familiar with this framework, it's a framework that visions how we respond to and intervene upon generational trauma. It involves individual and collective practices that transform the consequences of oppression on our bodies, our hearts, and our minds. And so at the Institute for Healing, Justice, and Equity, we do this work from this perspective. And as a psychologist, I think about my work as not only theory and research, but also the application. I'm a clinical psychologist by training. And so I also engage in a lot of public psychology. What does it mean for me to be a psychologist in my community and connected to my community? One of the things I want to highlight about healing justice is that it's community focused. So it means that we center those most impacted by systems of oppression. And it doesn't mean that we privilege the academy and the knowledge that we have in the academy over lived experiences. So we really do privilege the knowledge that's in the community. Another thing is that it's collective, right? So like mentioned, there are individual practices, but there are also collective practices. I'll talk a little bit about the Black Healers Collective, which is an organization that I've worked with. I'll talk about them in a little bit, where we do collective grief practices and collective gatherings, and now virtually, of course. And it's also interdisciplinary. So at the Institute for Healing Justice, we have folks that are in public health, communication, law. We also have faculty affiliates in sociology and medicine, and really do try to connect folks from all sorts of disciplines, because in our perspective, this work is not owned by one particular discipline. So that's a little bit about the Institute and how we do this work. Oh, it went forward. But the ways that we engage folks vary, but I categorize them in these few ways: through collaboration, through connection, and through translation. And I want to just say a few words bouncing or connecting to what the two other speakers said, and connecting with some of what they were putting forward. This idea that these systemic inequities have been here and that COVID is simply highlighting them. And so it's really important that if you're wanting to make an impact in the community at this time, that you think about the importance of relationship. Who are you in relationship with, and how? Because it's important that that be authentic. We can't give someone resilience. It's something, we can offer people practices that cultivate resilience, and to understand that that is often inherent, especially in groups that have been institutionally marginalized, that the groups that have been institutionally systematically over time put in positions where they have been oppressed, they have a lot of resilience. And so to assume that you can go into a community and give resilience, I think it's really important that we understand, especially from the academic perspective, that we want to partner with people and cultivate the resilience that they have in them inherently. We can prepare the environment, we can set optimal conditions, but we can't force resilience. And so to me, it reminds me that we need to be really clear about doing equity work and making sure we're centering that, so that we can have the environment so that people can live their best lives, that we can have that culture of health. The other thing that I want to just highlight in terms of my work, I talk about how we can help people understand the systems of oppression that are around them. So whether you're coming from the educational perspective around FRERE, or in the psychological perspective, we talk about how you might understand the structural stigma that's around you. So to give folks agency to understand what's happening, and to not assume that we need to go in and necessarily fix people, but how do we fix the environment and the system? So some of the ways that we do that is through collaboration, connection, and translation. So I'll talk briefly about a few different ways that we do that. So the other piece that I wanted to make sure to mention is that we at the Institute talk about how we humanize equity. So we think about, of course, the policies and the practices that need to be in place, but also, who are the individuals most impacted, and how can we connect with them? So we try to do that in a few different ways. So collaboration, if you're looking for ways to reach community, to connect, to support and foster that resilience, you want to think about how can you do things like this webinar, like webinars. And so we did a few that were around stopping the trend. We did one that was on healing justice approaches to self and community care, that included practitioners that were non-traditional, some that had that were in nursing, some that were in social work, some that were in the community and were activists. And so trying to think about who can you connect with or collaborate with to bring awareness and around the issues and the ways in which that your institute or your work might help or serve. If you know the work of Brian Stevenson, he also talks a lot about proximity. So we've talked a lot about how can we be in collaboration so that we can be in proximity to folks most impacted and that we want to be working with. So this is another example. So in some ways, I think we're kind of zoomed out or webinared out, but in other ways I've seen, and today is a testament, that people are hungry to continue to reflect and think, how can we do this work in a real meaningful way and have an impact? So the Movement for Black Lives is another organization that I was on a webinar with, and that we were able to think about from again, different perspectives. How can we learn from each other and be in community around solutions? So the Black Healers Collective is one that I mentioned earlier. And I would imagine that most cities have something like this, collectives of folks from different backgrounds. So we have people who are massage therapists, who have their master's in divinity, who are acupuncturists, psychologists, nurses, activists from all sorts of perspectives, but they're coming together to think about how do we work towards the liberation of our community. And so this is just you'll see the graphic over there, some of the ways that we brought community together. We've had healing circles for men, women. We had a parenting and pandemic and healing circle, one around essential workers, one around thinking about just how we politicize our healing. And then there are also gatherings, yoga, meditation. And so the Black Healers Collective has been really pivotal, I would say, in St. Louis in trying to bring community together. After the Ferguson uprising, after Mike Brown's death, we came together and created this collective. And so I would encourage you again to remember that a lot of times when people are taking action in moments of crisis, it's built on relationship that has existed before the crisis. And so if you're finding yourself wanting to connect with community and not quite sure how, look for things like these collectives and find how you can be in partnership. And then also find yourself in places where you can build the community so that you can be perhaps closer to folks and have that trust so that you can be in action in a different way if that's what you want as things move forward. This is just to give a visual. I think it's important that we also remember that we get to have fun. So this is a live stream discussion that I hosted that was about Insecure. So you might know that show on HBO. And so I think it's really important when we talk about resilience that it doesn't always have to be serious. Like, I need to give you resilience. How can I also help you connect with the joy that you have in life, the fun that you still have access to, even though things are really tough? So we had a debrief around Insecure. We also had, I mentioned the parenting amidst the pandemic. I did a version outside of the Black Healers Collective that brought folks together from all over the country to talk about what are the challenges about being a parent at this time. And many people talked about how that was helpful to be in community in that way. So I encourage you to think about, are there small ways that you can bring folks together to help them feel in community and like they're not alone in the midst of all of this. And then one of the last things I'll share is the podcast that I have had for, I guess, about a year or so. And the reason why I think that this is an interesting way for folks to think about how do you connect with communities, because it's a way that you can translate perhaps the research information that you have or the policy perspective that you have. How can you translate that for a broad lay audience to help them frame and understand what's happening for them? And so this is just a collection of some of the different titles that we've had over the past couple months, right? We've talked with folks who are in the medical profession, and one ER doctor talked about how, in a way, the COVID sneeze and the way in which it's so contagious is just as deadly as a mass shooting. And this doctor is involved in the pandemic response here in St. Louis. We've talked about finding your resilience amidst the pandemic. We've talked to small business owners, family that had COVID, the whole family. And we have seen in people's comments and reactions that you sometimes feel like when you're doing even some of these webinars or podcasts that you're maybe out in the void, but folks are engaging around it. It's posted so people can have conversation around it. It helps people feel connected to others who are having similar experiences at times where they might not be able to tap into that connection. And I also think it does help folks feel resilient and tap into their own resilience as they hear the stories of others. So I will pause there, and I thank you. Let's see, can I stop sharing?
Kara, there have been so many questions in the chat box, and I want to kind of see if I can sort through some of them. A couple of questions are, how do we kind of center new models of resilience that do not kind of like support traditional ideas of hierarchy, in particular racial hierarchy, but center new ideas and models for resilience?
I think that's a great question. I think we have to start doing just that. That's one of the things that at the Institute we're trying to start to archive some of the different models and practices that I think are happening in grassroots organizations, happening outside of the academy and even in some nonprofits. And so I think it's a matter of us being in conversation with each other and then being able to disseminate some of those best practices, or what I actually like to call next practices, because I don't know that we have the best practices for this sort of work, but let's be innovative and cultivate new ideas. I think now is the time to be asking that question. So I don't have the answer, but I think that is the right question to ask, because we need to be innovative about how we move forward in this work.
How would you suggest we overcome just like historic mistrust that's, just been really kind of amped up at a whole different level in COVID-19? People mistrust every source and form of information they're receiving from the highest levels.
Yeah, this is a perfect example of how, if we had that culture of health, if we had done this work before, there are some binds that we wouldn't be in right now. And so I actually don't think you can overcome that right now, like this, in the moment. I think what can help, though, is acknowledging it. So rather than saying, oh, I wish we didn't have this history of medical mistrust, or, I mean, of course we wish we didn't, but to name it and acknowledge it, to say, I understand that you might be skeptical about us pushing mass vaccinations in terms of, I talked to one organization who was going to say, well, we're going to require the flu vaccine of everyone. And it's like, well, you might want to understand how that might land on some of the, especially in St. Louis, some of the Black folks who are very skeptical about the medical system, and rightfully so. And so we talked about how it might be important to think about naming and acknowledging that mistrust, so that, I know that there is this history and that you might be skeptical for these reasons. And here's why. We're trying to decrease the number of people who are going to need healthcare, period, so that we can make sure we're available for those who have COVID. And then also not be frustrated if you're met with that barrier and mistrust, because it's founded. And so it took us a lot of years to build that mistrust. It's going to take us a lot of years to deconstruct it, but we can deconstruct it if we're intentional about it.
Thank you. Kira, we're going to shift just a moment. Alonzo kind of typed in, and he wants to share a resource I think that would also connect into what you just shared. Alonzo?
I put a link in to our webpage. We have a book coming out just a few weeks, Oxford University Press, that looks at kind of challenges the notion of progress, like GNP, that doesn't really connect us all together, and offers some substitute ways of thinking about it through well-being. And that also has a chapter from Anita Chandra that picks apart this issue of resilience and some of the things that have come up in the Q&A, how we have to be very careful to define this in a way that's not disempowering and even more marginalizing. Folks, I always say when I give talks on this, single mom, a service sector worker, takes public transportation to drop her kids off to school every day and comes back. That's a tremendous baseline of resilience right there. You have to lift that up. So
Mhm.
we think this volume we try to keep it not too academic. It's got practitioners, very much resonates with what we're talking about here today. And it's
Alonzo,
free. We'll give it to anybody who signs up for free.
we'll make sure that people get that link. So we're seeing people say, send me a copy. We'll make sure. Alonzo, thank you. Your point is so well taken. When I see images of small children in urban centers walking to school back and forth every single day, that to me demonstrates amazing resilience. So thank you for that. I think we're almost at the top of the hour. We may have time for one more question. Kira, I just wanted I asked Alice about kind of her rural setting. I've asked you about an urban setting like St. Louis, in fact, where you've had a large number of African Americans that have actually died from COVID-19. What are you seeing on the ground in terms of how the community, how individuals and the community are coming together?
So I've seen some beautiful examples of mutual aid happening in the city, and that's been heartening. And as you mentioned, we have the disproportionality. So the first several deaths were Black women in the city, and so we're interesting because St. Louis City is and a little bit of the county took steps and measures to have a safer at home policy, and in a way we're at odds with the state in terms of policy. So it's been an interesting push and pull, and I'm seeing a lot of grassroots collective action around, all right, if we're in a state that's not taking the same steps that are necessary, that we feel are necessary in the city to protect those of us that are disproportionately Black and brown and lower SES in the city, what do we need to do? What do we need to do ourselves to be in community and take care of each other? So I would say it's been fascinating to see the ways that mutual aid has been popping up, not just in the Black community, but also in the trans community, and the LGBTQ community. So communities are helping each other and connecting across those lines to be there for each other, because we are seeing the numbers here, and it's not over yet.
Kira, thank you so much. Alonzo, Alice, thank you so much for your comments. This has been such a fabulous session. I want to make sure that folks know that we are actually going to be posting this on each of our websites for Community Campus Partnerships for Health and for the UNC Center for Health Equity Research. Please check out the discussion board on CCPH's website to continue the conversation. And you can drop us a line, use this evaluation and QRS code to make sure that we know how we can improve this. We're making changes each time, every week. Next week, though, we're gonna take a minute, take a breath, and to prepare for our next set of webinars. I do want to make sure, though, that you know about the kind of content that's available next week. Can I have the next slide, please? So Al Richmond will be joining Adeze Enekwechi, the President and CEO of Impact Health, for this webinar on equity in the time of COVID-19. This looks like it's going to be a fabulous webinar on Thursday, not Wednesday, Thursday, May 28th from 2 to 3, Fixing Broken Systems to Serve Communities of Color. You have the register link there. We've also been putting it out on Twitter. And please join Al as part of this panel that is going to be talking about a systems approach to address equity during COVID-19. I want to thank everyone for joining us today. And again, thank Alonzo, Alice, and Kira for your insightful comments. And we're going to end then today. Thank you.